Well, thank you everyone for joining us for Neurology Week 2021 and our presentation about tardive dyskinesia. I'm pleased to have my good colleague and friend, Dr. Julie Jimenez-Shahed, joining me. And we are going to review some questions which have come from the audience for this presentation, which will last just a few minutes. So let's start with a question. Julie, why don't you
yeah, sure. Yeah, we had some good questions during the presentation, so we're happy to elaborate on those at this time. So one of the questions that came up was about CYP2D6 genotyping and whether there is a specific requirement for this, similar to what we have become familiar with tetrabenazine, which, as we know, is the parent compound for both of the new VMAT2 inhibitors that are approved for tardive dyskinesia. So Rajiv, do you want to comment a little bit on the need for CYP2D6 genotyping and the recommendations for that?
Yeah, so, although the FDA recommended CYP2D6 genotyping for tetrabenazine, for a practical matter, this did not make too much sense, as it wasn't done for dose limitation in the tetrabenazine trials in Huntington disease, and it wasn't done for the purpose of dose limitation of any of the clinical trials of either valbenazine or deutetrabenazine in either tardive dyskinesia, or in the case of deutetrabenazine for Huntington's disease. And so I would not recommend CYP2D6 genotyping, and I would treat to efficacy and adverse effects. Now, there is a recommendation, however, that if you do have somebody who has poor CYP2D6 metabolism, you may want to limit the dose. And this is perhaps, from a practical perspective, most pertinent with respect to what other medications patients may be taking. So if a patient is on a strong CYP2D6 inhibitor, such as, for example, paroxetine, fluoxetine, or bupropion, it is recommended that the maximum dose for deutetrabenazine, instead of being 48 milligrams per day, be 36 milligrams a day. And similarly, for valbenazine, the maximum dose, instead of being 80 milligrams, should be 40 milligrams per day. So just be aware of that. And effectively, by reducing the metabolism of the active metabolites, when you have a CYP2D6 inhibitor, you're getting more for your money, so to speak. So you don't need as much of the actual drug, valbenazine or deutetrabenazine, when you have the CYP2D6 inhibitor to have the same clinical effect. But again, titrate to efficacy. And you can see here, when we look at the CYP2D6 inhibition of the active metabolites of deutetrabenazine, alpha and beta dihydrodeuterabenazine, you can see what's going on there. And similarly, we have the same thing that goes on with valbenazine. So again, titrate to efficacy, and just be aware of what are the strong CYP2D6 inhibitors, and you should, from a labeling perspective, limit your effect, and I would not recommend genotyping.
Yeah, I think that's a very practical recommendation, because, as you said, this was not specifically recommended or even conducted during the clinical trials. And so, what you mentioned, which was the effect of this situation on these medications, is just that you would end up having more of the active metabolite in the system. And so there might be more side effects. So if you're just doing due diligence and monitoring your patients appropriately for the common side effects of these medications, then you will know where to end your titration if they're experiencing these problems. So hopefully that helps people in their approach to treating patients with TD and doesn't or eliminate some of the potential restrictions on using these medications. Great.
Well, here's a question for you, Julie. What is the typical process for a patient to get on the medications? They're expensive medications, they're often from specialty pharmacies. Is there a pre-approval process, or do you need to go through some sort of step therapy?
Yeah, this is a very good question. These are medications that are, as you alluded to, available through specialty pharmacies. Now, the good news is there's a lot of different specialty pharmacies that are popping up, and there may be some that are closer to you or that you might be familiar with as you're trying to use these medications. But generally speaking, there are treatment forms for each of the drugs that need to be filled out. And when you have determined that this is a patient with tardive dyskinesia and who would benefit from one of these medications, you simply fill out the treatment form, which has information on it about the patient's insurance, how to contact the patient. You send that into the central number that is included on those forms, and then an agent from the company will reach out to the patient to start initiating the process of getting the medication covered by the insurance. Now, when we are using these medications for management of tardive dyskinesia, there usually is not too much of a difficult step therapy process because there simply aren't other medications that are approved to treat tardive dyskinesia. So usually in most situations when that is the indication for which you're prescribing, these can go through fairly smoothly. However, there may be a lag time, and both of these companies do initiate the process of sending medication out to the patient so they can get started on the medication while the insurance process is the insurance paperwork is being processed. So it usually goes through pretty easily. I think once in a while I have seen where, we have to document what other treatments we may have tried for patients, but I think that would be less common in this diagnostic scenario. Do you have similar experiences?
Yeah, I would agree totally. There are one or two other points I might add. One is in certain states, an AIM score severity documentation may be required, especially for certain state-funded plans, like certain state Medicaid plans require an AIMS documentation. So you might want to think about that as including the AIMS severity score in your documentation, and sometimes it'll go through more easily or may be required indeed. The other thing is because they are expensive, many patients cannot afford the medications unless they're on a patient assistance program, in my experience. And just because of the current regulations of specialty pharmacies, they often are not allowed to tell patients about patient assistance programs unless the patient asks. So when I give the prescription to a patient, I tell them, the specialty pharmacy is going to call you. It's going to come from some funny 800 number. Pick up the phone, because most of us don't pick up the phone when they get a number because they usually think it's a scam if they don't recognize the number. So you have to tell your patients, pick up the phone, otherwise they won't get the medicine. And the second thing is, as soon as the people call you to verify insurance benefits, immediately ask, tell me about the patient assistance program. And then they're allowed to. Their lips are unbuckled because there's some OIG guidelines which prevent a lot of the pharmacies from proactively informing patients. So simple stuff.
Yeah, but very practical, because I think sometimes that's the hard part about getting these things through is getting in touch with the patients themselves. So good advice there. All right, I think this was another question that was posed during our presentation. So what tips do we have for differentiating an atypical tardive dyskinesia from a functional disorder? And I think this is an interesting question because there are potentially some overlaps in sort of the patient population and some of the clinical features that we might see. And so how do we really kind of feel confident that somebody is experiencing really symptoms of tardive dyskinesia as opposed to a functional movement disorder?
Well, I think I reviewed it a bit earlier, and we had a great discussion just before we started this recording. I think it's important to review some of the diagnostic criteria for tardive dyskinesia, such as the fact that it occurs after exposure to an antipsychotic or other dopamine receptor blocking medication for some period of time, and that it has certain characteristics, such as you might have withdrawal emergent dyskinesia. It may be suppressed somewhat if the dose of D2 blockade is increased. And of course, the distribution of the movements is typically oral buccolingual. And if you have movements only in someplace else, that may raise suspicion that, this is not TD, because TD usually has oral buccolingual dyskinesia, and then you may have more widespread movements. If you have absent that, unless you have a purely dystonic syndrome or purely akathisic syndrome, it's not likely that is TD. And then there's a variety of the classic things one might look for in somebody who has a functional movement disorder, which include, of course, distractibility, response to suggestion, and lack of, and other non-physiologic features. So Julie, one of the things that we often teach our fellows is, when you have patients do rapid eye movements with the hands in some other maneuver like that, that's often distracting in somebody who has a functional movement disorder. But in patients with TD, that will typically activate the oral facial movement. So that can be a helpful thing. Other ideas that you might have for the group?
Yeah, I mean, I think, the TD sort of does tend to follow some specific patterns, right? And so I think a lot of TD recognition is pattern recognition. And so the most common being the orobuccal-lingual stereotypies, and I think a lot of people are very familiar with that. And so if you see that, I think there, really should be a high index of suspicion that this is an organic manifestation, especially in somebody who's had a known exposure to the neuroleptics. I think the other kind of common one that you alluded to is the dystonia, which, can take many forms, but certainly somebody who has kind of an epistotonic posturing and kind of inversion of the internal rotation of the upper extremities, arching of the back, and retrocollis. This is also a very classic tardive dystonia kind of pattern. And so even though it might seem like there are some features that are inconsistent or just seem maybe a little too kind of prominent in some ways, may prompt consideration of a non-organic manifestation. Really, that's a very classic pattern, and if you see it, should really prompt suspicion of the tardive dyskinesia. I think as you were saying, when we kind of teach about functional movement disorders, some of the classic features are that they're sudden in onset. And there may not be this sort of gradual evolution of the problem, although once it starts, it may kind of build on itself and become more and more just increasingly evolving into more severe manifestations. But usually there's sort of a time point where patients can say that this problem started. Whereas with TD, it's a little bit more subtle, and you have kind of this subacute sort of onset of it, which then, probably, takes a period of time to evolve. But once patients have developed what they've developed, it's actually relatively stable. So those are some other kind of things to think about in sort of the history and the examination. Now, these are patients who do have psychiatric history, and so we know that that is definitely a association with patients who have non-organic movement disorders. But I think, when you've got sort of the classic phenotype, when you've got sort of the known exposure to the neuroleptics, and it's actually often even the case where when I see the phenotype, then I start thinking, oh, I need to ask about the neuroleptics. So it really is kind of very, closely closely matches what we kind of well understand to be the phenomenology of tardive dyskinesia. And I don't know, Rajiv, have you seen too many kind of atypical cases that you thought might not quite fit what you would expect to see in tardive dyskinesia?
I would say that's very rare. No,
Yeah.
I don't really. I think it's more often that we'll see somebody who has tardive dyskinesia and then also has another drug-induced movement disorder, like drug-induced tremor because they're on valproate. And then from time to time, as we spoke about just before we came on, somebody who has a functional movement disorder plus tardive dyskinesia because they have such severe psychiatric problems, and then they have a functional movement disorder too. And so that's a mess and a very difficult management situation. You really need your psychiatric colleagues to help.
Yeah, I would agree with that.
Great. So let's go to the next question. So, Julie, do you use Haldol, or is it too risky to use these days?
Yeah, that is a really good question. I personally actually don't have opportunity to use much haloperidol in my practice as a neurologist, but I think that there certainly might be situations where, this is an appropriate medication for a patient. And so, I think when we look at kind of the epidemiology of tardive dyskinesia, we understand that the first generation antipsychotics certainly have a greater risk of provoking or producing tardive dyskinesia and the associated phenomenologies that we just talked about. But, when you're approaching the patient, you want to certainly give consideration to, what diagnosis is being treated. You want to understand, kind of the history that this patient has had with other treatments, and you really want to choose the medication that is going to work the best for that individual. And while, we do talk about certain risk factors for tardive dyskinesia, such as older age and female gender, African-American status, longer exposure to these DRBAs, we do want to choose carefully. But in the end, if somebody really needs to use that medication for treatment of their underlying psychiatric disorder, then, you just counsel them, I think, appropriately about the use of these medications and the potential associated risks and monitor them. And I think that's really kind of the name of the game here with tardive dyskinesia, is to look regularly for these different patterns that we talked about so you can recognize it sooner.
Excellent. I don't have nothing to add. That's exactly right on. So our next question is, does new onset tardive dyskinesia result in reduced intellectual ability or intelligence? So to the best of our knowledge, this is not really the case. It's simply that tardive dyskinesia is associated with so many issues and problems. So if you happen to have tardive dyskinesia, develop tardive dyskinesia, you have, by association, you're more likely to have reduced intellectual functioning. And some of that might be because of the underlying psychiatric problem, which of course affects cognitive capacity. That may be because of the drugs you're on. So if you're on an antipsychotic and it's sedating, you're going to be less bright. There's no doubt about it. And similarly, if you have tardive dyskinesia, it's more likely that you're going to have a more severe psychiatric illness. You're going to have relatively treatment refractory disease, and you're going to respond less well psychiatrically to your medications. And it's not necessarily because the TD has caused you to respond less well. It's simply that because you have such severe disease, you've had to try high doses and multiple doses and many different medications for a long period of time, and that puts you at risk of developing TD. And then maybe because you've got TD, you get depressed, you're embarrassed, you're withdrawn. That has a secondary effect, which makes you even harder to treat. And so it's a vicious cycle. And as a result, you may be more likely to end up in the hospital again. So to sum up, TD itself causes certain things, but TD has so many associations because of the underlying risk factors. And then you have the secondary effects of getting TD.
Yeah, I would just add to that, a lot of times obviously TD, you have to have been exposed to a dopamine receptor blocking agent. And a lot of times what we still see is a co-administration of an anticholinergic medication to prevent the extrapyramidal symptoms. And I think that's often sort of they're co-prescribed for that reason, but realize that these can also augment the cognitive deficit, any underlying cognitive deficits that a patient might have. And so we also know that anticholinergic medications can sometimes worsen tardive dyskinesia. And so if that's the case and you're concerned about a patient who has those combination of features, then you may want to really think about eliminating the anticholinergic medication.
Yeah, a common term that has come out recently has been the word de-prescribe. So de-prescribe the anticholinergics. So I think that's all we have today for all of you. I hope that this review of questions has been helpful for you. And we hope that you'll be able to make good use of this information in your clinical practice. Thanks again.
Thank you.